Hi, and welcome back to hemodynamic monitoring. If you have not looked at the first pre-lecture recording over hemodynamic monitoring, you need to stop this one, go look at that, work through that, think about that before you come to this one. This really is a quick guide to help you put it all together. You should be able to answer these questions I'm about to ask and get, we're going to label a diagram and get that labeled. So this is a review, so please go back and look at that original where it talks about and explains what is preload, afterload contractility, what measures it, what are the normal values, how do we treat it if it's too high and too low. So what you need to do is I want you to get a blank sheet of paper and draw a Valentine heart like you see on your screen, and then quarter it, so divide it left and right and top to bottom. And then I want you to label it as you see on the screen, right and left, because this is a patient's heart. So if you took this piece of paper that you're drawing on and hold it up to your chest, flip it over, that puts this right side where the right atrium is of a patient, okay? So it's always helpful to do right and left. So this is right atrium, right ventricle, left atrium, left ventricle. So what we're going to do is we're going to use this diagram to put everything we know about hemodynamics, get it all in one spot. So let's start with preload. Preload means volume. So write the word preload equals volume. And when we measure preload, we are going to look for a CVP, central venous pressure. Any central line can give me a CVP. Sometimes that central line might be out here. Sometimes that central line is going to stop here. It may be called a right atrial pressure, so you will see that in some textbooks, but all of that means central venous pressure, or CVP. And normal CVP is 2 to 6. Okay, so let's talk about how to treat it. For low CVP, that means my value is less than 2. I need to give them fluids. What kind of fluids? Normal saline LR. I give them volume expanders like albumin. I will give them blood products if they are bleeding. And after I've given them fluid, because we always start with the easy stuff first, then I will move to a vasoconstrictor like epinephrine, norepinephrine. Two most common. Phenylephrine is also one. We do see that at times. And then the big daddy called vasopressin. You only see vasopressin with cardiogenic shock and septic shock. Those are usually the 2 times you see vasopressin. For high CVP, that means my patients in fluid volume overload. They have too much volume. I need to give them a diuretic. Because a high CVP means I have too much volume. A low CVP means I have low volume. So I'm going to give them a diuretic. If that doesn't work, then I'm going to give them a vasodilator like nitroglycerin or nitroprusside. I also want you to think about what your assessment data looks like for people with low CVP, high CVP, same thing with preload and contractility. All right, let's move to afterload. Afterload means resistance. That is the resistance the ventricles have to overcome to get blood out. We are going to specifically look at SVR, systemic vascular resistance, because the left ventricle pumps out to the systemic circulation. We did talk about PVR, pulmonary vascular resistance in congenital heart defects, because that can pose a problem for that. But I'm going to shorten this up. We are only going to focus on SVR. Normal SVR is 770 to 1500. This is all about resistance, and it's all about what your vessels look like out in your body. So if I have low SVR, that means I don't have a lot of resistance. That means my vessels are vasodilated. So open your hand up really big. And how do you fix it? You need to vasoconstrict. So make a fist. That's a vasoconstriction. What medications do we use? The same meds we talked about. Epi, norepinephrine, phenylephrine, vasopressin. If I have high SVR, my vessels are really tight. That's like a little coffee stirrer straw. Because for low, that's the boba straw. The high is for the little tiny coffee stirrer straw, which means it's really hard to get your milkshake through that. So that vessel's tight, so make a fist. And how do you fix it? If it's high, you vasodilate. And you use things like nitroglycerin and nitroprusside. Okay, hope it's all coming together. Say this out loud. Draw this out. Your family can help you study this because they can give you, you can ask them to give you numbers and you decide how to treat it. Now, they may tell you that your CVP is 147. That's not possible, but all you have to do is think it's really high. Now, of note, what I want you to think about is we can actually change CVP fairly quickly. On my shift, if my CVP were 8 to 10, maybe even up to 12, I give a diuretic. I may repeat that diuretic. I actually would expect that CVP to come down to a normal level like 6. SVR doesn't change that quickly. Cardiac output and cardiac index don't always change that quickly either, but it's pretty easy to change CVP. Also, if my CVP is 0 or it could even be a negative number, I give the patient a couple of liters of fluid volume, that CVP is going to come up to 2. That's going to happen. All right. Now let's talk about contractility, and that's the pumping of the heart. And how is that measured? That's measured for cardiac output. Normal cardiac output is 4 to 8. Cardiac index is more specific. It is 2.5 to 4.2. That's probably the hardest number to remember. And how do we improve pumping? Because we're only going to focus on poor pumping, decrease cardiac output. We're going to give our inotropes, and that's milrinone, dobutamine, and dopamine. So 2 D's and an M. Now, DIG is actually an inotrope. We don't use DIG very often. You will only see people probably who've been on DIG for a long time using DIG. We have much better medications, so we're not using it very often. But fundamentally, DIG is also an inotrope, but the ones you need to remember are milrinone, dobutamine, and dopamine. There's hemodynamics right there. So, what measures it? What's the value? What does it mean? What do I do if it's too low or too high? What are these medications? What does my patient look like? How would I expect them to look after I've treated them? So, here's the next slide. I want you to write down patient signs and symptoms for increased preload, fluid volume overload. I want you to write assessment findings for decreased preload, fluid volume deficit. And then I want you to write signs and symptoms of decreased contractility, which we've talked a lot about in class already. Because if my CVP were low, these were the assessments I would expect to find. If my CVP were high, these are the assessment findings I would expect to find. Same thing with decreased cardiac output, because we can't just rely on the number. We can have our equipment cannot be zeroed correctly, which we'll talk about in that second hemodynamic monitoring video that starts with invasive hemodynamic monitoring. Sorry, it's late tonight and I'm having a hard time talking. Monitoring, hard word. So their assessment should correlate with this, which should also tell you if I have these signs and symptoms. So increased preload, that's heart failure. They're going to have crackles, JVD. They're going to have an S3 or an S4. They may have some edema. Bounding pulses. Well, I would expect their CVP to be high as I give them a diuretic and maybe start a vasodilator to displace the fluid. I would expect those signs and symptoms to get better. Now, edema's not going to get better on my shift, but their crackles should get better, maybe even go away. Their JVD should decrease. Their shortness of breath should get better. Their bounding pulses should get better. So you know what your goals are, and then you know now how to evaluate if you're meeting those goals and the patient is doing what you're thinking. So this is important. Write this down. All right, the last thing you need to write down is I have learned that you students can really rattle off you can say, oh, it's milrinone, dobutamine, dopamine, nitroglycerin, nitroprusside, vasopressin, epinephrine, norepinephrine, but when I ask you which one's a vasopressor, which one's an inotrope, you have a real hard time. So you're going to write these down and you're going to write these meds. You can actually do the signs and symptoms and meds on one 3x5 card. If you don't write really big, you can put your heart on the other side in one little 3x5 card or a 4x6 card. You have everything that you need to know. So write down your medications, your vasopressors: epinephrine, norepinephrine, vasopressin, phenylephrine. Vasodilators: nitroglycerin, nitroprusside. Inotropes: milrinone, dopamine, dobutamine. All right, I hope that helps. As you study this content, come back to this video to see if you can get them all in there, get them in the right spot, know what they look like, know what your values are, know what you need to do, know what your goals are, and know how to evaluate. Thank you.